We'd like to go ahead and get started if everyone's ready. I'd like to welcome everyone here this evening. My name's Ed Crowder, and I'm very pleased to welcome you to Medicine Forward tonight. I'm excited as we kick off our 2026 Medicine Forward season. And for those of you who have not had a chance to join us before, this speaker series connects the community with the School of Medicine's researchers and clinicians to explore how research taking place at Wake Forest University School of Medicine is transforming medical education and healthcare delivery. This evening, we're focusing on advancing discovery through research and innovation in medicine, and we're excited to hear from three of the Dean's research scholars. They are Dr. Joseph Rigdon, Dr. Elizabeth Jensen, and Dr. Kevin Gibbs. They're all leaders in their field, and we want to congratulate them on being selected as Dean's Research Scholars for 2025-26. Yay, guys. Well, Joe, you shouldn't clap for yourself. It's bad form. Tonight, they're going to share with us their research that's shaping the way we deliver care and improving outcome for patients. But first, I'd like to introduce Dean Ebony Boulware, who will provide some general updates about the school and introduce tonight's speakers.
So good to see you. Thank you for coming. If I haven't met you, I'm Ebony Boulware. I'm the Dean of the Medical School and the Chief Academic Officer for Advocate Health. I'm so delighted to have you here. Medicine Forward is a time when we just come together to hear what's happening in medicine, what are some of the brightest, most promising developments that are happening. And I just want to tell you that this is a really exciting time for the Wake Forest University School of Medicine. We're really thriving in so many different ways. On the educational front, our programs are all really thriving in MD education, PA education, nursing education, our master's and PhD programs in science, and all these programs are growing and expanding and modernizing all at the same time. We're so proud that we always turn out the best graduates in the country. I'm convinced of it. And we try to keep them with us, but they get stolen away when they graduate sometimes. We do our best to keep them here. And so that's one area that we're growing, and as many of you remember, we're almost one full year into the second MD campus in Charlotte, and that's gone quite well. The first 49 medical students are completing their first year, and they're excited, and we've got another set coming in already, so we're off and running, and I would say it's been a fantastic start to that campus. We've got 18 departments with new department chairs that are there, faculty, over about 1,200 faculty that are there teaching students and residents. The students are having a phenomenal time. It's really exciting to see faculty there with some of them, have the white coats, and we've got Wake Forest University School of Medicine, and there's just a lot of pride for us being in Charlotte as well. And then, I know you may have heard this before, but I just want to point out once again that Wake Forest University School of Medicine is what's called the academic core for Advocate Health. And Advocate Health is now one of the top 3 in size healthcare systems in the nation. And to be the academic core means we are the medical school, the academic engine for this huge enterprise, which has over 70 hospitals and thousands of care locations in 6 states. And we're really at the time of unprecedented innovation when it comes to that. Because most very large health systems, as they're coming together, are not thinking about innovation and doing the next generation, training the next generation, and really advancing healthcare that we need. And I'm proud to say that at Wake Forest University School of Medicine, as the academic core, we're really driving that for this huge health system. And I'll give you some examples. First off, we have one research infrastructure, which means you can go to one place and you can do research across the entire enterprise. One example of that is for clinical trials. Clinical trials is the way that we test new discoveries and new treatments, new medicines, and if you've come in contact with either yourself or a family member or somebody who's had cancer, for example, where you want to get the care is where clinical trials are done, because that's where we're testing out that next potential cure compared to the excellent care that's happening today. So clinical trials is one of the ways that we provide the best possible care to individuals across wherever you are. So we are able now to do clinical trials across the entire Advocate footprint, run through and powered by the Wake Forest University School of Medicine through something called the National Center for Clinical Trials. So all of the hospitals and all the care locations in Advocate Health are part of a huge network. This whole health system is now fired up and powered up by the school to do clinical trials across the entire footprint. This is a major step forward because in the past, if you were in a medical school, you wouldn't necessarily be able to do a clinical trial in so many different places. You'd have to work with another place, maybe 5 or 6 different other health systems, just to get enough people to do the trial. Now, with Advocate Health, we're caring for over 6 million individuals in the United States. So that means that we can get these trials out and we can get them to a lot of people, which means the trials get completed faster, which means the discoveries get discovered faster, and we can get those cures to the market and out so that we can use them. That's one way that we're powering the the discovery of this very large health system. Another way is, of course, through the individuals that we're training. We, of course, now our medical school has expanded to 2 campuses. Also, we are overseeing and coordinating all of the residency and fellowship training across this entire enterprise. And I want to say there's about 250 residencies and fellowships programs across the enterprise that we're now coordinating. And many of the people that have been doing this outstanding training are joining our faculty and very excited about that. They're very proud and energized. I actually was in Chicago on Tuesday for something called Celebrate Research. We're having a whole month of celebration of research across Advocate Health to really lift up research as being something excellent that we all want to have, and to really lift up the outstanding research that's happening mostly through our school across the enterprise. And I was delighted to see some presentations from some faculty members in Chicago, Advocate Christ Hospital, working in child and maternal health. And they all presented outstanding research that they were doing, and they said, I'm a faculty member at the Wake Forest University School of Medicine. And they had extra, I got chills. I was like, oh, wow, this is amazing, because the excellence of our school is really permeating this large health system. We're starting to see that. People are really excited and proud of the innovation. So I just want to let you know that, a big change like this is a big change for a school like ours that has been around for over 100 years. And, we've really been focused on excellence in North Carolina. But that excellence is spreading, and that's something really to be proud of. So I wanted to share that with you. So many different ways that our school is transforming. And I can honestly also say, other schools are looking at us and saying, this is really amazing what's happening. If you've had colleagues at other places, or friends that have been at other places, or you hear about other places, they've really faced some headwinds when it comes to their financing and staying and struggling to keep the academic mission alive. And we really have not been in that situation because of the enthusiasm of this health system to support the School of Medicine and the research. So that being said, there's so much exciting stuff happening. We're going to have graduation coming up in 3 weeks, 3 weekends. Yes, we got a graduate. Yay, congratulations. Class of 2026. I will be attending graduations, I think 4 graduation ceremonies in a couple of weekends. So this is an exciting time for us as we see people go through the cycle of their education. Tonight, I'm going to now shift to what we're talking about tonight, which is how we're moving medicine forward, again, through research. And I always say here at the Wake Forest University School of Medicine and here in Winston-Salem, this is the flagship. This is the powerhouse. This is where all of the discoveries really are being fueled through our best excellence. And tonight, I'm really pleased to present to you 3 Dean Scholars. Now, 2 years ago, I started a program for Dean Scholars to say, who are our best and brightest superstars that are coming up that we want to make sure we get to not only see their discoveries and see the work that they're doing, but we want to support them because we want to help their work go forward. We want to keep them here stay, and then we want to and we want to help them thrive here at Wake Forest University School of Medicine. And I wanted you to have an opportunity to hear the great work that they're doing. Inspired by all of their work, these are all national and international leaders that are going to be presenting to you. And so this is really going to be an opportunity for them to present their work. Then we'll sit down and have a panel, and we'll hear some questions and answers. So I'm going to introduce them to you, and we'll start out, and then they'll come up one by one and give their presentations, and then they'll sit in the chair. Okay. So, and they won't go anywhere. Our first presenter will be Dr. Joseph Rigdon. He's an associate professor of biostatistics and data science in the Division of Public Health Sciences. His work focuses on biostatistics and how we understand that things are whether or not they're associated with each other and whether or not they're caused. Whether or not one thing causes another, which is actually a complex area called causal inference. And he works in preventive medicine with a particular interest in lifestyle interventions. He also serves important leadership roles ahead of the Biostatistics, Epidemiology, and Research Design Group within our Clinical and Translational Science Institute. And so his research helps strengthen the scientific foundations behind discovery, making sure that we ask the right questions and we try to answer them as rigorously as possible. We also then have Dr. Elizabeth Jensen. She's a professor of epidemiology and prevention in the Division of Public Health Sciences. She is a nationally recognized investigator whose work spans reproductive, perinatal, and pediatric epidemiology. Her research explores how early life and environmental exposures shape health across the lifespan, and much of that work is directly informing the care of mothers, infants, and children. Her scholarship has a lot of scientific depth, deep scientific depth, and she also has a clear commitment to outcomes for patients and families across our communities. And then we have our third presenter will be Dr. Kevin Gibbs, an associate professor of pulmonary critical care, allergy and immunological diseases and internal. I got to shorten the name of that section. That's too long. I'm going to call it pulmonary or allergy, whichever one you want. All right. Dr. Gibbs is a medical intensivist and director of acute care clinical trials team, where he leads both conventional and randomized clinical trials and pragmatic comparative effectiveness studies involving hospitalized and critically ill patients. His research focuses on respiratory life support, including emergency tracheal intubation and mechanical ventilation, with the goal of improving outcomes for patients facing some of the most serious and time-sensitive medical conditions. So together, these represent the best of academic medicine. They're really making incredible discoveries, and so I'm delighted to have them present and for us to have this conversation. So with that, I'm going to go ahead and invite Dr. Rigdon up.
So my talk is titled Spreading the News, Maximizing Clinical Trial Impact for the Community. So I'm going to go through some background. I'll do some slides on the methods we'll present, talk about some preliminary results, and then tell you about some exciting next steps, building on the foundation that Dr. Boulware described. Okay, so who am I? I'm a biostatistician. I've been fortunate to be at 3 great institutions. Here at Wake Forest, I'm an associate professor in biostatistics and data science. And the focus of my talk is understanding clinical trials. My friend Dr. Gibbs here in the audience really broke it down nicely about clinical trials. He said, patients want to know, does the treatment work? And importantly, will it work for me? And so the second question is really the focus of a lot of my research is, does this result that we found in the trial apply to me? Will this treatment work for me? And I have a really motivating family story here. So about 15 years ago, my mom was diagnosed with breast cancer. She's okay now. I'll get right to the end. It's very good, a good ending to that story. But I remember when she and my dad were taking apart the medical literature with their clinical team, trying to understand what options would be right for her. I was a graduate student at the time, so I couldn't really weigh in too much on the literature, but it really sort of formed a motivating example to me of this is something that patients, family members, people I love and care about are really faced with, all of us are faced with. Do these results apply to me? How can I make the appropriate decisions for my care? So yeah, that's the motivation, and I'm going to present some work that tries to answer exactly that question of translating clinical trial findings into understandable and personalized results. Okay, Brief review here, building on what Dr. Boulware started with, the central importance of clinical trials here that really sit at the top of this pyramid here. So they are so important because they form an unbiased way to estimate the effect of a treatment. Is it working in populations? You know, at the base of the pyramid, we have opinions, observations. We even get into things like observational cohort studies where we observe people over many years and observe trends and patterns in those groups. But randomization is what's special about the acronym RCT I'll use as randomized controlled trial. And what you want to know about these is randomization makes them special. It makes their conclusions really important. And we're a leader in this realm here at Wake Forest, and especially with the building of the Advocate National Center for Clinical Trials. So what happens in these special trials? So the first thing we start with is a research question. You know, will this new treatment work in this population of ill patients, for example? Then what we do is we try to recruit those patients into the research study. And here's maybe the most important part of all, is that after recruiting them, we randomly allocate the treatments. We randomly assign one group to, say, the standard of care or the control group, and then one group to the new therapy we're thinking might do better. Then we follow them in time, and we look at, say, the rate of bad things, the rate of the outcome that we're trying to prevent in the two groups. And so in this sort of toy example, the treatment group is experiencing 6. Only 6 of 100 are getting the bad thing, and the control group is getting the bad thing 12 of 100 times. And we have sort of statistical ways to say, is this significant? But this is the general idea. One of the most famous trials coming out of Wake Forest that actually ended up changing medical guidelines is called the SPRINT study. In this study, investigators were looking at intensive blood pressure control at a target of 120 systolic versus 140 systolic, with the goal of trying to prevent the bad thing of a composite cardiovascular event. And the text may be a little small here, but the nice thing about randomization is at the onset of the trial, if you looked at study baseline, we have about 4,600 in each group. And if you look at the distribution of age, sex, all the important variables, it's about equal. And I liken this to almost lining up horses. Kentucky Derby is about 2 weeks away, and so we have these two horses at the starting line, and all things are kind of equal, and you sort of follow them in time and wonder which one will win. So that analogy sort of works, I think. And in terms of which will win, what we have here is we're measuring the rate of bad things. Here, a composite cardiovascular event, and we see the orange line, the intensive treatment, is having like less bad things than the blue line, and significantly so much that the trial was stopped early at about 3 years. We can quantify the difference here between orange and blue with something called the hazard ratio. It's sort of fractionally how small is the orange relative to the blue, and we see about a 0.75 right there. And so this trial actually informed national guidelines to the point where the blood pressure control target has been changed to 130 because of these results. But going back to the way Dr. Gibbs framed it, do these results apply to me? If I'm a patient considering controlling my blood pressure, will I get this benefit of lowered cardiovascular events? The standard approach to this question is to look one variable at a time. Like we see previous cardiovascular disease, we see age. We sort of go one by one and see in these subgroups, are there differences versus the overall hazard ratio of 0.75? Limitations of this approach include it can be dense to read as a patient, and then also it only looks one variable at a time. Each person in this room is a combination of multiple of these variables, and you might wonder, what if I'm over 75? What if I've had previous cardiovascular disease? Where do I fall on this chart? Okay, so we have a new statistical method that we're using that can look at all of these variables together and make a nice figure here at the end to try to form a decision tree that patients and clinicians alike can read kind of down the tree and say, these are the variables that matter. And then once I get to the sort of end of the tree, these are the risk profiles of the treatment for me, the benefit profiles, I should say. So we have applied this method to SPRINT, and we identified that age was an important factor, and then previous cardiovascular disease was also an important factor. And I say important factor because if you go back to the overall trial findings and you look at this orange and blue line, think of that as like an anchor for the overall trial results. You can see in these, I'll call them subgroups we've identified, there are sort of different risk profiles of orange versus blue as we look across these three subgroups, and different hazard ratios too. And so our vision is that whether it's something like this or something like this, we envision a world where we can publish these type of pictures along with the trial to help guide patients and clinicians in selecting whether or not this treatment is right for them. So that's kind of where we are in the research plan right now, is we have these preliminary results with Sprint. We're working with a group of patients and stakeholders. I actually see one in this room right now who's been really helpful in thinking through these visualizations. So we're working to create the right picture that can be published along with trials to help guide patients and doctors in making these important choices. And the last thing I'll say is we've done it for preventing kind of the bad things, the primary outcomes of the trial. We're also starting to look at adverse events and whether those differ between these two groups. And then the really nice thing about these tree graphics is pictures have this, we've all heard this statement of pictures can be worth 1,000 words. And I really believe if we get this graphic right, it can communicate the benefit profiles in a way that's quick. It doesn't rely on internet connection, which is important for rural health, and it can help facilitate a meaningful doctor-patient conversation. So thanks for your time today.
Good evening. So tonight I'm going to be talking with you about some of my research, but as I give this talk, my goal for you is to understand that this isn't just about research, that it's also about making an impact on the families we care for every day. And as an epidemiologist, the pursuit of designing and implementing research that is tightly connected to answering questions that have genuine consequence has come to be termed as consequential epidemiology. So Catherine Keyes and Sandra Galeo are two very well-known epidemiologists, and they really have advanced this term of consequential epidemiology. But at the heart of it, it's about conducting studies on what matters. And so this is my journey. So my what matters is really defined by my mentoring, my teaching, engaging with others to ask the right kinds of questions. And this really comes from something that my father instilled in me. My dad passed away last fall, but if you asked him what was important to him, what matters was, it was truth and justice. So that was what he would say. I'd say, Dad, what do you need? Truth and justice. That's what he would say. So he made a big impact on me, and he lives on in me. So my journey started actually in Florida. I'm originally from Florida, and I have public health roots at this point. I worked at the Ounce of Prevention Fund, working on a child abuse prevention program, the March of Dimes, leading a statewide preconception health campaign, and the Florida Healthy Start program. And these experiences have what led me today to really spend a good bit of my research on maternal and child health. And so these are three areas that I do research on, but today I'm going to be talking about my work in maternal and child health. So as you can see by this figure here of the US, with the darker states representing higher pregnancy-related mortality, North Carolina has one of the highest pregnancy-related mortality rates by state. But what most people don't actually realize is that most pregnancy-related mortality occurs after they deliver the baby. So it's not during pregnancy, but after the baby is born. So this figure is showing that's roughly 63% of those deaths occur. All the way through 12 months, there's that increased risk. And it turns out that a third of it actually occurs in the first 6 weeks after delivery. And I'll come back to why this is important, because this is the crux of what we designed for a model of care. Now, the really heartbreaking piece of all of this is that a lot of these are preventable. As much as 84% are actually preventable. And then a little bit closer to home, one of the leading causes is just access to care. And so you can see here Let's see if my clicker will work. But Forsyth County here with the star, and looking at the surrounding counties, we see that there's low access to maternity care for some of these surrounding counties. And then in Stokes County, it's considered a maternity care desert. Now, what about infant mortality? Well, North Carolina is also not looking super great on infant mortality. We have one of the highest infant mortality rates as well, relative to other states in the US. And then closer to home, we can see, again, there's this pocket where we have higher infant mortality in Forsyth County and then the surrounding counties as well. Okay, so we have to do something about this, right? I think I've laid out a story that we need to do something. So what we have done is designed a health system integrated model for postpartum support, or the Nurse Education and Support Team, called NEST. So I started this program in 2020, and it coincided, unfortunately, with COVID. And so we initially had to offer this program as a telehealth-only program. But then once we started to open back up, we were able to pivot to home visits. So this is the model of care. It extends roughly 6 weeks, 3 to 7 total encounters. It's offered to every woman that delivers in our health system in Forsyth County. That's where we started. And we've since expanded, and I'll talk about that in just a moment. But it's providing education, support, clinical assessments, and linkage to community-based resources. And those community relationships are absolutely critical to the success of the program. But our primary objectives are to increase access and adherence to recommended postpartum care, to infant care, to decrease emergency department care utilization, increase awareness of and access to community-based support services. At the end of the day, we want healthier moms and babies. So there's a lot of numbers here in this table, but this is the first look at some of the results from Forsyth County. And we're starting to see evidence that we are making an impact, where we saw fewer hospital readmissions and emergency department encounters, as much as a 25 to 50% drop for those women that participated in the program. But now we're expanding into some of those outlying counties that I mentioned, where there's actually a good bit of need. And this is through a robust RCT design. Joe was talking about the RCT design. And we're randomizing mother-infant dyads to either usual care or usual care plus the NEST program. And it includes Davie, Davidson, Yadkin, Wilkes, and Stokes County. And we have about 900 mother-infant pairs that we've enrolled thus far. So impact is more than just about the numbers, and I just wanted to share a couple of little stories about impact that we've had with these families. So this was a family where the nurse conducted a home visit with a patient who was 2 weeks post-cesarean section, and she was reporting severe pain. During the assessment, the nurse identified a problem with the patient's incision site. The nurse contacted our OB triage to facilitate an urgent evaluation, and that patient was able to get into care more quickly as a result, ultimately reducing the risk of serious complications. And another story, the nurse visited a woman who was experiencing severe postpartum depression. The patient had documented a history of suicide previously, and at this visit endorsed active suicide ideation with a plan. So the nurse immediately connected the patient with perinatal mental health partners, where the patient was able to speak with a provider and establish care that very same day. And during the follow-up visits conducted a couple of weeks later, there was measurable improvement after initiating medication and therapy services. And then the last story I'll share is one that we see far too often, but this was again during a routine home visit with a patient with no prior history of disclosure of domestic violence. The nurse observed the partner displaying abusive behavior at the time that the nurse was in the home. We utilized an intimate partner violence screening instrument, and the patient disclosed ongoing abuse. The nurse promptly connected the patient with trusted community partners, provided education and resources for obtaining a restraining order, and placed a referral for mental health services. And with that support from that nurse, the mother was shown a way forward through a very, very difficult situation. Okay, I'm going to switch gears and talk about another project. This is the Remote Blood Pressure Monitoring Project, or what we call SMART BP. And so there are guidelines that the American College of Obstetricians and Gynecology specify for postpartum follow-up. And this is because hypertensive disorders of pregnancy are one of the leading causes of maternal mortality. But unfortunately, many women don't make it back into care in the postpartum period. And so this particular program was designed to try and address access to care issues and help us identify women who may be experiencing elevated blood pressures in the postpartum period. It turns out that lower risk women, women who didn't develop hypertension during pregnancy, actually account for the majority of readmissions, and nearly all of those before 3 weeks postpartum. So the consequences are severe for risks of delayed or misdiagnosis of these hypertensive disorders. Hypertensive crisis, seizure, stroke, all kinds of very serious consequences, including death. So our goals were to assess this remote blood pressure monitoring intervention for feasibility, adherence to these ACOG guidelines, and whether or not we would detect concerning blood pressures that could help us improve diagnosis and care management. So in terms of feasibility, we showed that by having the monitor, we were collecting blood pressures earlier, and we were collecting them more often. And for adherence to ACOG recommendations, we saw a marked improvement to adherence. And then this is the, I think, particularly exciting part of this particular study, which is we were able to detect novel, new, elevated and critically elevated blood pressures in the postpartum period among women who had not had a previous history of elevated blood pressure during pregnancy. Actually identified that these women, 7% of them had a critically elevated blood pressure in that postpartum period. And this is the impact of this study. The use of this app and participation in this study helped me catch preeclampsia early and ultimately saved my life before things worsened. I was able to keep an eye on my blood pressure after the post-preeclampsia hospitalization. So we actually learned that by implementing this study, many of our patients actually came into care that otherwise would not have known that they needed to come into care. Okay, so where is all of this going? So we do have some goals for expansion. Our goal is to, once this RCT ends in those 5 rural counties that I mentioned, that we will go ahead and offer services to all women residing in those counties. Our hope is that we'll eventually expand into additional counties beyond Forsyth County and those 5 counties within our birth center. But we really hope that one day we'll be able to expand this model of care into additional hospitals within our health system. We also have a new grant we're being supported by the Duke Endowment for this new grant, but it extends care through pregnancy all the way to 12 months infancy through a telehealth-based intervention, recognizing that while NEST is providing this intensive support for 6 weeks, there's still a need for a lower touch intervention for a longer period of time. But at the end of the day, again, we just want healthier moms and babies. And my What Matters is really informed by my strong collaborations with patient advocacy groups, community partners, healthcare providers, health system leadership partners, and a desire to impact the lives of women and infants in our community.
Those were 2 very hard act to follow. But I'll do my best. My name's Kevin. I'm really delighted to be here. I'm a medical intensivist, which means that I take care of people and families on some of the worst days of their lives. Today I'm going to talk about my research in respiratory life support, and we're going to talk about how we learn what works best in healthcare, how we can make life support safer through research. My agenda today is to describe what comparative effectiveness research is and why we should care about it. provide a real-world example with the work I've done at Wake Forest, and look ahead why I'm excited to be part of the Wake Forest University School of Medicine community. So what is comparative effectiveness research? So if you're like me and you rarely grocery shop, walking into a grocery store can be an overwhelming experience. And so if I'm tasked with buying hot sauce, this is what I'm confronted by, which is rows of hot sauce. And, how do I choose one? I may look at the label, I may look at the price, I may have a deep cultural connection to one of the hot sauce brands, who knows? But how do I know which one is best? Fortunately, we know the answer to that question. So it is Texas Pete. But how do we prove that? So maybe I arrange a blind taste test for my friends where I put multiple hot sauces in front of them, and we come to the conclusion that Texas Pete is in fact the best. And that's what comparative effectiveness research is. And shout out to my wife who painted both of these pictures. So this is a common challenge in medicine. Believe it or not, doctors and clinicians every single day in every single care specialty can face treatment decisions where there's more than one acceptable treatment. And doctors have to make that choice without knowing which of these treatments is the best. So how do they choose? Well, maybe they like the label. Maybe they were trained to pick one. Maybe there was an institutional or cultural conditioning to make them pick a choice. Comparative effectiveness research allows doctors to know which of the treatments is best. So this is the real-world example I'm going to talk about today. So again, I'm a medical intensivist, so I only take care of the sickest people in the hospital, and so my perspective is pretty warped. But believe it or not, people who are going to the operating room, I think of these people as quite healthy. And so there are two scenarios where people have breathing tubes placed. The first is in the operating room, and the second is in an emergency situation in the ED or the ICU. In the operating room, for mostly healthy people, complications from breathing tube placements are extremely rare, occurring in only 2% of patients. In contrast, bad things happen 20 times more often, or in 40% of patients who are having a breathing tube placed in an emergency situation in the ED and ICU. And it's not because we're worse at placing the breathing tubes, it's that the patients are sicker, there's a lot going on, and we're trying to put these tubes in rapidly under emergency situations. And so the most common complication that patients experience during placements of these breathing tubes is that their oxygen levels can drop. Drop in oxygen levels, even for a short period of time, are dangerous, and in fact increases risks of having the heart stop during the breathing tube placement. And that's important because that's a devastating complication. The patient is dying in front of you. And that actually occurs in 1 in 50 times where we have to place these breathing tubes. I can tell you this, there are not very many situations in medicine where there's a 1 in 50 chance that the person in front of you is going to be dead in the next 2 minutes. So the single most important intervention to prevent dangerous drops in oxygen levels before placing the breathing tube is having the patient breathe oxygen before you start. The two most common ways to do that are using these two devices here. Before the study we conducted, we didn't know which of these was better. The first method is a loose-fitting mask that provides pure oxygen to the patient. The second is a tighter-fitting mask that provides both pure oxygen and pressure to help the patient breathe. And these are both used in routine clinical practice. One doctor at one center might have always used the loose-fitting mask. Another doctor might have always used the tight-fitting mask, and we had no idea which one was making the right choice. So we conducted something called the Preoxy randomized clinical trial. This was a large study that was conducted at 24 different EDs and ICUs across the country that was led by Wake Forest University School of Medicine with our partners at Vanderbilt University Medical Center and funding from the United States Department of Defense. And we compared these two ways of giving oxygen before placing the breathing tube. What I love about this type of research is that this research is really carried out by frontline clinicians. So all the elements of the study are being conducted by the doctors and nurses at the bedside, and respiratory therapists too. And And this is really embedded in the day-to-day operations of the hospital units. And what we found in the study, I think, is practice-changing. We found that the tight-fitting mask that provides both oxygen and pressure cut dangerously low oxygen levels in half. And it reduced the number of patients who were experiencing their heart stopping during the breathing tube placement. And this is the type of results that this comparative effectiveness research can have. So looking ahead, I want to talk about why I'm just very excited to be a member of the Wake Forest University School of Medicine community. And I think Dean Buller and I did not share slides before this presentation. But I think there's a theme here that's going to come out. So Advocate Health, powered by Wake Forest University School of Medicine, is uniquely positioned to conduct this work. We have an unprecedented scale across diverse clinical settings. We have an integrated electronic medical record where all patient information is stored, and that is a key piece of information to conduct real-world research. And we have outstanding regulatory and institutional support for an integrated clinical trials platform. And also, Wake Forest University School of Medicine is innovating in ways to collect high-quality clinical data that makes this research really feasible. So this is the bottom line. Medical decisions aren't always guided by clear evidence, and whenever you go to a doctor, they are having to make choices that they don't absolutely know the evidence, or they don't know is the best choice for that patient. Comparing standard treatments helps us make better and safer choices, and it's a really exciting field of research. And I'm just very proud that Wake Forest is a leader in this kind of research. So that's all I have, so thank you very much for your time.
First off, I want to acknowledge these three brilliant people presented us with a lot of data and a lot of numbers. And so as I was sitting and reflecting on this, I was thinking, maybe one of the more important things, because you all really highlighted this, is to talk about data. And one of the things that I think is very interesting, I don't know if people know this, but the trust in medicine and the trust in data have gone down significantly in our country. And it's really affecting how people are actually, whether they decide to take a medicine, whether they decide to go to the doctor or get health care. So this concept of the data, quite frankly, it's fairly intimidating, and the three of you are all experts in data. So one of the things I thought I'd first ask you about is couple of things. Why did you decide to come into areas where your research was really mostly based on data? And there are a lot of alums here, and I'm also of a certain genre, let's say. And I remember when I was in medical school, and the way we learned about medicine is you'd maybe go to the New England Journal of Medicine, and there was a great review article. Some expert had said, this is how you treat a urinary tract infection. And there was very little data. It was actually just this expert saying, this is how you do it. And we would learn from that. And there was almost an explosion in data when we began to be able to collect it more easily and get it, the findings became more rigorous. This is in Stone Ages. Actually, it wasn't that long ago. But what I think is fascinating is that what we've had is an explosion with the use of computing, et cetera, in the use of data, but now people don't trust it. So first I want to ask, why did you each go into fields? What attracted you about fields that focus on data, and why is that important?
So I mentioned that I had worked in different public health settings before going back and getting my PhD in reproductive perinatal pediatric epidemiology. But I worked for different programs for which there was a lot of heart, but not necessarily the evidence base behind them sometimes. And so I think that was honestly the biggest motivating factor for me. I felt that I needed to get the training to be able to do the research and build the evidence base and figure out what works and what doesn't so that we can use our limited resources wisely. So I worked for a home visiting program for the Healthy Start in Florida. There was so much just challenge with limited resources and these different programs trying to serve the families. And at the end of the day, I just wondered, okay, how do we do this better? How do we do this more efficiently? How do we create the evidence that we need to really make a difference for moms and babies? So that's the why for me.
Great, thanks.
Mine's maybe short and simple. I think it's the universality of math and data, like 1 + 1 = 2 here in China, Ecuador, anywhere you go, right? And it's, but the challenge, at least in the research I'm pursuing, is how do we present that data in a way that's accessible to everyone?
So making it understandable.
Exactly. Yeah.
And I thought in your presentation it was very interesting because you showed us different ways that data can be shown. And I saw different ways data were shown in all three presentations. For example, you showed graphs of estimates. You showed pictures of like denser, darker areas, lighter areas. You showed 100 people with one, so there were different ways that the data came out. Can you talk about that and why that's important?
I think, it's the impact we're trying to have. We're trying to empower patients and doctors to make the best choices for them. And so we have to do it in a way that makes it accessible. And what I've started to appreciate in the project we're working on is people really do come at these problems from very different contexts and very different standpoints, and trying to synthesize, the qualitative piece of things to inform the quantitative, to understand how people are perceiving the images you show them is really important to move research forward.
Thanks. Thoughts on use of data? You talked a lot about how there's a lot, we just actually have multiple choices, and yet so can you talk a little bit about that?
Yeah, so I love being a doctor and I love being a clinical trialist. I think these are two of my favorite things in the entire world. But nothing makes me more frustrated than having to make a choice that I don't understand why I'm making that choice. And for me, that's the thing that drives me to want to do research. I want to be able to tell patients and their families, we are doing this because we know that this is the best option available for you. And you need the data to do that. Otherwise, you're just listening to my opinion.
That's how it used to be, though. We just listened to the opinions. We thought we were doing okay, and then we realized we probably needed more data. So can you talk to us a little bit about the stories that drove you here? You each all had kind of shared a personal story. Can you talk to us a little bit about how you keep those stories sort of front of mind as you're thinking about your research, as you're thinking about the impact? We could start.
Yeah, I'll go first. I think the thing that continues to motivate me is that I know every single day patients are getting exposed to treatments that may or may not be helping them. Or may not, that's not fair. I think that may not be the best treatment for them. And that's in every part of medicine. And, it drives me to want to do this type of research just to be able to say, like, no, we should be going down this path. This is the safest thing for the patient.
Yeah, I mean, I shared the story of my dad. One of the other things that he used to say to us is, you need to grow up and make a contribution to your fellow humankind. Like, that was drilled into us from day one. So I think that is what drives me forward. And so when I hear these stories of the impact that we're making with these families, in my other areas of research, I work quite a bit with patient advocacy groups. I just find it just truly incredibly rewarding. I came to Wake Forest because I wanted to be in a school of medicine. I wanted to be close to actually making an impact on how we care for patients. And so I left the School of Public Health to come into the School of Medicine for that reason.
And I think for me, it's everyone in this room, including myself, will face difficult choices one day with limited time and money. And how do we empower people to synthesize the available data and information to make the best choice for them? So that's what drives me.
keep the mic. How are you seeing things change? We talked a lot about all the data that are available now. There's also a lot of discussions about AI and how we're applying. Everybody, I'm sure, is ready for a question about AI. Can you talk a little bit about how you're seeing things change in your field and the advancements and where you think we're headed?
Absolutely. I didn't get into it during the methods part of my presentation, but the method we're using to discover subgroups does technically use some AI, though it's sort of some transparent, explainable AI. Like if you were to listen to a different presentation from a statistician like me in this field, you might hear a talk where they would present sort of a risk calculator where you would input your numbers and out would pop a prediction of what happens to you on this treatment and what happens to you on that treatment. I think that's a really exciting field, but I think a challenge there is that the explainability isn't there. You don't know what's driving those predictions, whereas if we can create the right picture, we can kind of read it from the top down and say, okay, age is a risk factor, CVD is a risk factor, this is driving the formation of these subgroups. So what we've tried to do in our research is take some of the benefits of like data-driven AI kind of discovery, but also do it in an explainable way so that patients and doctors can understand where these predictions and conclusions are coming from. But there's sort of range of opinions here. Like you might hear someone like me say, no, that the explainability doesn't really matter as much. We just want to get the prediction right. It doesn't really matter how we get there. I think this is an active field of discussion, and I think it requires patient voices and doctors' voices too, and that's what we're trying to bring into our research is do a lot of listening too.
I think it kind of flies over our heads. I think, are you alluding to in the sense of like a lot of AI is not clear how it comes to its conclusions.
Exactly.
So it's like a bunch of equations that come up with prediction after prediction and sort of predicts the next thing, but then it can get so complicated we can't even understand how it's getting to that answer.
That's exactly it. And I think, I'll try not to get too philosophical for a second, but with this idea of what happens to me on this treatment versus that treatment, we're sort of entering the realm of what you could call counterfactuals, things you can't observe in practice. And so you have to make some assumptions to train AI models in that setting, assumptions that may or may not be true. In the setting of not a counterfactual where you're trying to just look at, okay, what's my risk of heart disease in the next 10 years? It's not sort of bringing in what about treatment? This is absent treatment. In a setting like that that's just predicting what will happen to me, independent of thinking about my treatments, AI can work really well because we can validate the prediction versus the actual observation of what happens to me. But when we're trying to evaluate treatments, we can only evaluate what happens to me on the treatment I actually get and not the one I don't get. So that's where you're kind of making some of these logical leaps.
So break it down for us. Is AI going to be doing a lot of these calculations instead of humans in the future? Or how do you see AI coming into helping us understand what treatments work and what treatments don't work?
This is such a great question. There's a researcher at Duke named Cynthia Rudin who has thought deeply about this, and she has this really nice paper the gist of it is stop using black box AI for these really high stakes decisions because we need to know and we need to have accountability as to where the conclusions are coming from. So that's certainly an emerging viewpoint. Some are more aggressive in how they're using it, and you could throw all your data into ChatGPT and say, hey, what happened? What should I do? And so I don't want to completely dismiss that viewpoint. The story is kind of unfolding, but I think we just have to be careful as we proceed.
So being careful about AI.
Yeah.
Dr. Jensen, any comments about AI and how it might affect your area?
Yeah, I would say AI isn't a big part of my research, although those of us that are epidemiologists talk about using, other kinds of methods that sort of look like AI. We call things AI that actually AI has been around longer than just the last few years. So there are methods where we put a whole bunch of different things into a box and then output like a prediction model. That's been around for decades and decades before what we know is AI.
So not really affecting your area so much at this point.
No, but I'm not an early adopter, I'll say, on the AI.
You're a skeptic. You're a skeptic. All right.
Yes.
Okay. Dr. Gibbs.
Yeah, so AI touches all elements of the job I do, and I think it's very interesting because that's That's a new phenomenon. Talking about the clinical trials work, I think the most exciting development in clinical trials in the last 5 years has been the type of work that Joe does and that AI does at some point. Joe explained this well, but when we talk about the results of a clinical trial, we're talking about the results on average. How does it do one group compared to the other? It's not answering the fundamental question of, will that treatment work for me? Because I'm not the average. And so the methods that Joe is using, one of the alternatives is to use AI-like technology to try and estimate the effect of the treatment on the individual. And this is an emerging field. We don't know if this is going to work, but it is the most exciting development in that space, in my opinion. And then as a doctor, AI is changing the way that I interact with the electronic health record, and changing the way I look up information. And it just is. And so I think we need to be appropriately skeptical. We need to be academically rigorous. But this is a paradigm shifting technology as far as I'm concerned.
I hope folks are thinking about any questions you might have, because we're going to open it up. One of the things I was struck by was looking at the patterns of maternal poor maternal outcomes in North Carolina, and you talked about our specific area. And it's striking. We might go through our day to day, and we're not necessarily realizing that these outcomes are occurring sort of at a higher rate than we certainly want them to happen, and even across the country. Can you talk about how it's important, the research that all of you are doing, how you feel like you're contributing to that effort to make sure that everybody can get that best possible health outcome?
Well, that's certainly central to a lot of the work that I do in the maternal and child health space. It's something I think about all the time. You mentioned something about just trust and how we trust data and whether or not it's based on opinion or data. And this is actually something I think quite a lot about, because as we go into different homes, there has to be a level of trust in order to encourage, motivate that family to go back in for care, or to get the needed treatment, or to take their infant in for the appropriate care, or for safe sleep. And what it comes down to is relationships, and people will trust people that they have a relationship with. Mm-hmm. And so that's central to a lot of the work that I do.
Yeah, a lot of the findings that you showed was like when a person reached out and actually had that human interaction, they may not have had a long relationship, but that there were improved outcomes.
I think where my mind goes is if we can work with our team to make the right picture to display the conclusions to this problem of, will this treatment work for me? I think we can use graphics and pictures to make the findings accessible. This is my hypothesis, at least, and both for individual trials, but then if we can do that for each trial to sort of facilitate a holistic conversation, looking at multiple trials, multiple graphics, doctor and patient kind of going through each one and thinking about sort of the whole picture, pun intended.
Any comments from you? Do you have any comments?
Yeah, I think one of the reasons why I'm so excited about the expansion of clinical trials opportunities across our healthcare system is that I genuinely believe that participating in clinical trials brings the best care to the patient. And so I think even regardless of what treatment the patient is receiving, participating in the clinical trial will improve their care. And I think that is just one of the kind of real benefits of the direction our institution is traveling. So.
Anybody in the room participate in a clinical trial before? You got a couple. I think that's fantastic. Hopefully you had a good experience. What we always say is the clinical trial care is actually more protocolized, so you actually get more standard because you really have to make sure you're on point with making sure that everybody gets what they're supposed to get. A lot of people don't realize that. They think they're worried about being experimented on. It gets back to this trust component.
Yeah. The thing I would say is that the next time, if you are walking through the M level of the hospital is very confusing. But on the way to the cafeteria, there is actually a statue that looks like an egg, and each of the bricks in the egg is actually a piece of art that a patient or their family of a clinical trial participant made, and I spent a lot of time looking at this, and I think one of the things that really strikes me is that the participants and their families want the best treatment for themselves, but one of the major motivators for participating in clinical trials is actually a sense of altruism and wanting the best for others. And I think that's magical. So thank you everyone who's participated or who's considered participating. So.
I think I saw a question over here.
I still want to talk about the AI situation. It seems that Advocate Health, with its access to the clinics and 70-plus hospital, whatever, you have a tremendous database or access to tons of electronic health records. And as you know, AI models thrive on data that is gathered, and the more detailed, the better. Summaries don't really get you there, and so if you can get the real level of detail, then you get a really good model and a chance of having a good decision made or a suggestion made by the AI model. And my question is, how does HIPAA interfere with the access to that data collection so that you can have a good database that gives you a really good model? Are you able to access data at the very detailed level so that you can build your own very trustworthy AI model?
You want to take that? You can take it and then
Take it. Yeah, so that's a great question. There are lots and lots and lots of protections in place for any electronic health record data, so it's important that folks understand that. Now, electronic health record data are collected for clinical purposes, billing purposes, but not research purposes. So while there is incredible rich data from the electronic health record, it's not the panacea that we might think. It's complicated to get data out of the electronic health record. And if it's free text, it's even more complicated. But we do it. But when we pull it out, it's a de-identified data set that you're working with. So there are protections in place, and there are people who are responsible for pulling the data out that are not necessarily the same as the people who are actually using the data and analyzing the data. And then every study is governed by our Institutional Review Board, our IRB, which is responsible for reviewing all human subject research and making sure that it's ethical and appropriate.
Can you comment on his question about the amount of data, and is that helpful in doing
Oh, it's
studies?
incredible. Yes, there is a huge opportunity there, absolutely, using the EHR data, for sure. And your point about needing that level of data is absolutely spot on. You need that many observations so that you're not just identifying spurious associations.
And I will say that we've had an explosion of the use of AI, and in one of our prior Actual Medicine Forward, we had Dr. Akbilgic here, who talked about taking, I forget how many millions of EKGs there are in the system. Using that, he's now been able to come up with a way to predict heart failure long before patients have clinical symptoms, individuals have clinical symptoms. So we're increasingly using these types of data to do detection and early treatment. So huge opportunity. I saw another hand here. Yeah.
This is about maternal health, and you can tell me if this is right or not, but I understand that sometimes black women have more fatalities and that maybe their symptoms aren't taken as seriously. And I wondered how your research and the programs that you have going would affect that.
Yeah, that's a great observation, and that has been reported many, many times in the literature, that Black women are more likely to be dismissed when they report experiencing pain, for example, and may be treated differently. This is a critical issue of our times, and one that, yes, we absolutely are thinking about. And some of my other work, and I didn't have a chance to mention some of my other work, but one of the things that I'm really interested in is this idea of perceived discrimination and whether or not people are experiencing that in medical settings. And so your question is spot on, and I think it's an important issue.
I have another question.